Hi, Henry.
Hi, Mary. How you doing? Thank you for presenting.
Yeah, I was just talking to Erica St. James, who's our EM ultrasound director, and she was like, "Oh, I know Henry. He was a PEM fellow when I was an ER resident." So she's like, "Oh, I remember him."
Oh, okay.
Yeah.
That's awesome.
She's our director for ultrasound for the emergency medicine side of the street, I guess we could.
Yeah, yeah. Oh, that's awesome. Yeah.
Yeah.
Yes, thank you for presenting, by the way. We usually give
sure.
everyone to like 105, start
Okay,
going.
that's fine. Yep. You might hear the Blue Angels are here tomorrow and they're practicing right now. So
That's awesome.
but they're buzzing by the, what do they call it? Buzzing by the tower. Hopefully it's not too loud, but. You guys can see my slide, my first slide, right? Okay.
Yep. Yep.
Okay.
That's fine. But you're in the presenter view?
Oh, yeah.
You know, like just so I'm not sure. Is there anything I
like that? No, that's the wrong way. Just kidding.
There you go. Yeah.
Okay. Well, now I can, okay. It looks like the regular view to me. So let me see.
Yep. Yeah, now it's working. Now I see the whole slide.
Okay. I can't see the presenter view part. So I'm going to see if I can flip this. Hold on, maybe if I do it like this for a minute. Oh, geez, I got multiple things open here.
Yep.
All right, what do you guys see now?
The presenter view.
Oh, okay. Well, I don't know what I'm doing wrong, but usually I can do this. Okay. For some reason, it's not letting me. You guys don't want to see that. I know what I'm talking about. Okay. Well, let me know when I should get started.
No, it's 105. Yes, I was going to say, yeah,
Okay.
Good afternoon, everyone. Thank you for presenting. Today we have Mary coming all the way from Buffalo. So thank you again for presenting, and you can take it away.
Sure. Thanks. Thanks for letting me be here. I started watching some of these videos last year during COVID, and so it was really fun to watch and listen to all of you. And I hope you continue it for a while, because I think there's a lot for people to learn in this nice environment. So thank you for doing this. And there's so many things to learn, and so it's been great. And so I will show you what we have, just a few cases. I think I have about 10. I don't know if I'll get through them all, but I do want to just give a shout out to the fellows. These are some of their images. So we don't have a PEM ultrasound fellowship. It's a PEM fellowship here. We have 2 fellows a year, but Rush, Asher, and Matt, some of their slides are their images are on here too. So the first case was a 4-month-old who came in with a history of failure to thrive, was admitted to our hospital about 2 months of age for failure to thrive, had a workup, went home, was on special diet and had nursing coming out to the house and stuff like that, but came in with increased worker breathing and vomited. Noted to have retraction and grunting, and was tachycardic when they got there, a little bit febrile, very tachypnic, enough to just go right into the resuscitation room where they were able to get some labs, but then had to place an IO. And just before intubated, our fellow just threw the ultrasound on the chest, and this is what they saw, which was kind of striking and unexpected, but it helped to decide what kind of shock this patient was in, seeing this enlarged heart with not much of movement of that mitral valve there. So they ended up, it's like sticking, sorry guys. They ended up, I'll just do it like this maybe, going ahead and starting epi and then soon after milrinone. But I think what was striking was that just this one view was enough to change the management and how they were moving along with the resuscitation. So big old heart, one view. I think this parasternal long can be one of the most valuable views, especially in a quick situation where you need to make a decision quite fast. So I hope everyone can appreciate the dilated ventricles and the lack of movement of the mitral valve. I'm sure all of you have had cases like these that are like, oh boy, we got to move to the next, onto the next thing. So the next case is somewhat similar to this, where it was a person with a known cardiomyopathy who had increased work of breathing, had been on milrinone, and then that was stopped a couple months ago, was not having a good day with like decreased urine output and decreased PO intake, and didn't get their Lasix in the morning, came in, also tachypnic and tachycardic. Gas was okay. They tried on high flow nasal cannula, eventually got this chest x-ray, but then after reviewing this ultrasound, which was also quite striking for the dilated ventricles and lack of movement, also helped them kind of move into the right direction, and not thinking this was solely respiratory, but that there was not only this patient did have a cardiac history, but it was striking how bad this echo did look. I think the EF was eventually like read as about 20%. So it was really helpful for them to do these images real quick before they started going in the wrong direction, but there we go. Little help. That's your A4 view. And again, just not a lot of movement of the heart in general, but that mitral valve is barely moving. So the next case was kind of funny too, not funny, but was a 21-month-old Amish girl. I don't know how many of you in the community have the Amish or Mennonite population, but these kids are really tough and can handle a lot. And they come in at the last minute. So this one had a history of propionic acidemia, the whole family did, but had some involvement with cardiology, but I don't think anybody really knew how the status of this child's heart was. It's obviously unvaccinated, but came in with increased work of breathing for about a week and then vomited a lot that day. Came in tachycardic, tachypnic, stats were okay, but had some delayed cap refill. Didn't notice anything really on lung exam, and labs were basically okay. And the fellow went in and did this cardiac imaging I'm going to show you in a second, but he said as he was doing it, she was pretty rambunctious and wanted to just get down, sliding off the mom's lap kind of thing. They did find on a chest x-ray there was a left lower pneumonia, started on Zithromax and ceftriaxone, but this was her EKG, which another surprise, right? I don't think anybody expected it to, this heart to look this bad. So again, very little movement and huge dilated ventricle with little movement of the mitral valve. We didn't do color flow, which is the next step in our kind of workup, but it was just kind of striking for everyone to see these images. And then apparently after this happened, about a half hour later, she seized, but when the doc went in there, she was actually coding and needed resuscitation, multiple rounds of epi, but they did get ROSC. But to have somebody looking fairly decent, and then to have this type of echo, and I think the post-resuscitation echo, the EF was like 18%. So I don't know where she was at this point, but I'm sure she wasn't much better. So it did, not that it necessarily guided, but it certainly alerted everyone to how significant this cardiomyopathy was in this patient. And anybody jump in at any point, I'm just going to kind of go along.
Was the etiology of the cardiomyopathy known, or was it just assumed by?
Yeah, I think it's not well documented in there, but I know that it had said that she was had seen cardiology in the past. I think it might have been one of those check boxes. If you have propionic acidemia, you got to see the cardiologist type of thing, because she wasn't on any medications. So I don't, maybe there was one visit in there, but it wasn't the first thing the family said is, oh, she's got a bad heart or something like that. It was, oh, she's fine. She's just been vomiting and having tachypnea. So it was a little bit of a surprise. And other family members were still alive and older than she was and doing okay, apparently. So it was a little bit of a surprise, but helpful to do. This one I've had, like, I have two cases similar to this one. The second case is further in the list, but this one kind of bothered me for a little while. It was a 4-year-old who came in with fever and vomiting for about 24 hours. And prior to that, it was about a week ago, where it was a 24-hour period, and then kind of did okay for the week, had decreased PO, didn't really stool, so had been doing like stool softeners and suppositories, and then came in when I saw her a week later with fever, vomiting again, tachycardic, febrile, and blood pressures were okay at that time, but looked dehydrated, kind of tired appearing, a little bit of abdominal distension. We did labs on her. We kind of did a sepsis workup on her and was thinking kind of missy type of stuff too, because things were coming back, not strikingly abnormal, but the white count was 3.4. The sed rate was elevated. The gas was okay. EKG just showed sinus rhythm. CMP was basically normal except for elevated glucose of 138, which wasn't that big of a deal. But we did these x-rays on her. She had a just abdominal series for the most part, which showed some dilated loops, a little bit of air fluid levels, but nothing, you know, and you can see some dilated loops here, but wasn't that impressive. So I took in one of the residents, and he was doing this as I was guiding him. And I don't know if you guys run into this situation, but when people are unfamiliar with the machine, you go from one side helping with the machine, then you got to run around the other side of the bed and help with the probe. So we were kind of going back and forth. So the images, you know, could be lined up a little bit better. But what I was surprised when I was looking at this, and tell me if you disagree, but I felt like there was a little pericardial effusion, a little extra fluid up here that I wasn't expecting to see. And the function of the heart looked really relatively good, but I just felt like there was this little effusion. And I kind of showed the cardiologist when I talked to him, and he said, yeah, there's a little one there, but we'll see her tomorrow, kind of thing. But then I did go down to her belly a bit, and this is just one of the images I did. I didn't spend a ton of time in the right lower quadrant, but I kind of just went right to heart to left upper quadrant. And I just felt like the bowel looked fairly inflamed, the bowel wall. I didn't actually, there isn't a measurement, but just using the measurement on the side there, I'm guessing this is at least 3 millimeters, roughly around there, which I think is considered abnormal. I didn't see like to and fro peristalsis or anything that made me think necessarily obstructive, but certainly abnormal. And I was surprised to see both. Okay, so I got a white count of 3. I have a small pericardial effusion. Now I have inflamed bowel. What am I dealing with? In a way, we ended up putting an NG down and tried an enema, and she ended up going to the unit. Then they did a chest x-ray the next day that showed that she had pneumonia. And then 2 days later, they did an abdominal CT because she kind of got better and then got worse. And the abdominal CT ended up showing a ruptured appy with multiple abscesses, which kind of hurt me a little bit because I wasn't sure if I missed something there. But I thought it was weird to see so much inflammation and different parts of the body, and then have that as a diagnosis with a white count of 3. I think 2 days later, the white count went up to 18 and the D-dimer was like 7. But the rest of the Missy stuff was unremarkable. And she had rhinovirus. Rhinovirus seems to be a stinker these days. I don't know about in your lands, but it's causing all sorts of problems. But does anybody have any questions or thought about these images? Kind of weird. This one I had to bring up just because I've seen it in a couple other cases with this series. This was a skier who we do have skiing around here in our southern tier, big hills, not mountains, but this 14-year-old was tearing down at the bottom and had to come around a sharp turn, and he ended up kind of ascending into a pole basically, and he came in with a bit of a bubble butt. But this is kind of what we saw over his sacrum area. So we kind of looked with the ultrasound across the sacrum. I know these aren't awesome images, but tons of fluid in that area. And I think they ended up deciding it was the Morella Lavale. So I think that's come up a few times. I think somebody showed it in a knee, but this was the CT. Hopefully this will work okay. But when you get to kind of about here, you start to see a lot of fluid kind of throughout over the gluteus there. But it's like it happens in Buffalo too. This was it was silly for him because he walked around, he was uncomfortable, but he had a lot of swelling to his butt. But it was interesting when we did that just to see how extensive that fluid was, collection just without really borders. It just kept on going. So CT or surgery got involved and wanted that CT. So this case is probably the most interesting. I'm sure this is something that people don't see very often, at least in our country. But it was a 2-year-old female who probably by now has been diagnosed with autism, but came from another facility with petechiae and joint pain, hadn't been walking for a couple of weeks. Had a CT of the head that was negative, was anemic, and then transferred to us. I think the weight was actually less than 16. I think that was the weight when I looked at it now, but I think she was more like 12 kilos. Was tachycardic, ill appearing, had petechiae and bruises, poor dentition, swelling to the ankles and knees. Hemoglobin was 6. The rest of the labs were basically okay. D-dimer was a little bit elevated and albumin was low, but there was a concern for abuse and neglect. So skeletal survey was done, and then they found bone demineralization and multiple fractures. But this is what our fellow Matt Weiss found this is the distal femur. I'll just let that run for a minute, but you can see kind of a layering of hypoechoic area with maybe mixed echogenicity in there. And then right along that growth plate, it looks like extra bone, could be cartilage potentially, or cartilage production just right about here per our radiologist afterwards. But this is just another view of what that kind of looked like. It has a little seizure at the end. But this was her x-rays, and you can see just this area that we were kind of looking at, and that was most likely that she had some hemarthrosis and subperiosteal hemorrhage from scurvy. So she had a very low vitamin C level that was performed a little bit later and has been on a different diet, and that has been improving now. But I found these images and I thought they were kind of interesting. These nice radiograph of this this Pelkin spur, which is I think what we were seeing on this other image. It's very hard to find any literature about this on ultrasound. I think there was one case report in the past 10 years. And this image is from that, which I have referenced. but it's uncommon to look at the scurvy on ultrasound. But what you're kind of seeing here is that subperiosteal hemorrhage here in this area. And I'm sure over time you might see more calcifications building up. But I think this is that Pilkins spur as one of the radiographic findings. Some of the other things that you can see are the Wimberger's ring and the Frankel's line, the Trommerfield zone, all of our just little things that you can see on X-ray that probably can see a little bit on the ultrasound as well, that pencil point cortex. But I thought that was a really interesting, unusual case. I think there's some other pictures I have too of just how this bone looks with these little calcifications in the subperiosteal area that most likely from the hemorrhage over time. And so this was infantile scurvy. It's unusual. I think breastfeeding kids, it's unlikely to happen up until about 6 months, but because we don't produce our own vitamin C, we have to get that from our diet. I think we're one of the only animals that does that, that can't make it. So you do see it in those people who overheat their food apparently, or like they just don't get it in their diet. And apparently she had like a major food aversion, and I'm not exactly sure what she was eating, but it didn't have any vitamin C in it. So just some other images of this case, some skeletal radiology in 2015 of how someone kind of compared the ultrasound findings with what they found on the X-ray. So again, this the subperiosteal hemorrhaging, that's that pencil point cortex, and actually I'm gonna move us over a little bit, but that's kind of what we saw on those images that our fellow did. So I don't know. I thought that was pretty neat. This was later when that patient received treatment. There were these little calcifications in that subperiosteal area that you can see over time as they get treatment when you have that resorption of that hemorrhage. Has anybody seen that? Has anybody seen scurvy at all?
No, never seen. And on your first image, there seemed to be like also inflammation, you know, in the fascia and the muscle area as well.
Oh yeah, yeah.
So, yeah.
Up in this area, yeah. I didn't see her myself, so I don't know what kind of state she was in, but I guess not surprising. She wasn't walking, so I'm sure there was a ton of inflammation in there. Let me see about this one. If we look at this one again, this one's not my favorite one. Kind of does a little jiggle at the end there. I think there's, let's look at this one. Again, yeah, just interesting how all these spikes in the bone, it looks like, but I don't see as much inflammation of the muscle in this one. But yeah, it was a very unusual case, so I thought maybe you guys might enjoy that one.
Yeah, definitely a good case.
So one more cardiac case, and this one I will enjoy any conversation about what your experiences have been, but it's tough enough to do a 6-day-old's cardiac exam, but this one came in for increased respiratory rate and was basically like hypothermic, and so had a full sepsis workup. Stats were like 100%, but the ended up being put on high flow nasal cannula, and prenatal stuff was fine. It was a C-section, but full term baby. No issues with previous cardiac or the fetal exams, but the fellow was working the overnight, we call it pretending shift. So in the morning, he told me this patient was going upstairs. I didn't have to do much, but he had done these images. It's sticking, sorry. Here we go. And I had to like stare at them for a little bit to appreciate what I was finding, because it didn't look normal. Not that I've looked at a lot of 6-day-olds echoes, but here, let me keep this one going. But it seemed like the the right atrium and right ventral were very large, and also the left atrium and the left ventricle wasn't as big as I'm used to seeing. So that was kind of surprising. I'm going to just show these again just so everybody can kind of, because it's not looping, I apologize. I think this one's kind of nice too. So you can see left atrium, right atrium, and then right ventricle up here, which compared to the left ventricle just looks pretty small. There's some more pictures here. This baby ended up, the cardiologist agreed that those were some of the findings, but also found a coarct and a VSD. And so I had to go back and look at this for a while to see if could I see the perimembranous VSD, which would be right in this area right here. And probably had we done some flow, I wonder if we might have been able to see something popping through at where a perimembranous VSD would be. So kind of right in this area. I don't know if you can see my marker or not, but so it made me really curious about how can we better identify potential coarcts, since it is relatively common. I feel other things that we might be able to see on bedside ultrasound that would clue us in on that. And a lot of literature is based off on the fetal ultrasounds that they do, which isn't as helpful to us. But oh, by the way, the blood pressures were, the lower extremities were ended up being low, so that was helpful too. But so you guys probably all know Russ Horowitz, since he was part of the P2 POCUS, or maybe he still is, I don't know, but I think he was doing a lot with it in their earlier days. But he had this video that I found on this core ultrasound website, and I do agree with some of his thoughts that looking at both ventricles is important, and seeing if any of them are hypoplastic using the A4 view is helpful. And then, so starting with that, so I think a lot of people start out thinking, okay, I see good squeeze, I don't see a pericardial fusion, you know, I can measure the EPSS, I can do a TAPC kind of stuff maybe, but then where do you go from there? And this is where I'm gonna, you know, challenge myself a little bit more, but looking at, you know, more than just the ventricle contraction, but really appreciating the size, which sometimes is really remarkable, sometimes it's not. But then also using the waveform Doppler, looking at the abdominal aorta and the subxiphoid view, which, you know, we don't look at aortas a ton. Maybe you guys do, I shouldn't say that, but very rarely do we have kids with aortic aneurysms, but we did, we had one. But looking at that and appreciating what the flow looks like, and we should see a nice spike versus a more of a crescendo decrescendo look to it, which would be consistent with a stenosis proximal to where you're looking. So that would be kind of a fun thing to do. And I don't know how many people on the call have had that opportunity to try and do that. But also looking for heart failure by looking at B lines on your lung exam, which I think you might see a few anyway, being only 6 days old. But obviously, if you saw a lot consistent with true B lines, then that would be of concern. But it's a nice 5-minute talk that is on this core ultrasound. I did look up a few things about the aortic notch, because I know that we're doing a lot in adult medicine to look for aneurysms in the proximal aorta. This view could potentially be used. I don't know, again, how many people have had the opportunity to do this. I did this the other day, and it was a little disorienting. So it was something that I'd like to work on a bit more with our fellows too. But I think you just have to remember what side, where you put your indicator. So if you're used to putting your indicator on the left side of the screen, you'd put your probe here with marker dot going down. And if you like the indicator on the right side of the screen, then you put the marker dot going up. But you're basically touching kind of the long axis of the aorta as it comes kind of over So for you guys, it would be the left shoulder. But it's kind of, this is how it would appear. This is just a cadaver sample that I had to turn because it looks a little bit more like this when you're looking at it on the ultrasound, where you can see your brachiocephalic, left carotid, and then left subclavian over on the right side of your screen there. And then you could potentially see this little shelf where oftentimes the patent ductus might be existing there as well. And this nice round spot in the middle is your right pulmonary artery. So I'm kind of curious if people have had the opportunity to do this, if it's been real hard, if it's fairly easy to do. I know that you have to have them in a good position, probably holding still, which is hard when you're a month old, unless you got a pacifier that you really like, but lying on their back, and you have to have their head basically extended a bit. And it certainly takes some patience and time. But coarcts are fairly common, so and they can be associated with the bicuspid aortic valve. So I threw that on there just as, and this is what you'd kind of see with the Doppler ultrasound of the aorta and the subxiphoid view. This kind of pattern where it's kind of a slow wave instead of being a spike, that would be consistent with a stenosis that's proximal to where you're looking, which we see in other locations as well. But so something like if you've done some Doppler already, it might not be as, it might be familiar to you, I should say. So I don't know, have other people had the opportunity to look for these signs of congenital heart disease, either VSD or coarctation, when you're doing these focus exams?
Personally, here at Connecticut Children's, I usually don't look at the suprasternal notch area. And actually, like, for newborns, I don't actually look at the abdominal aorta, something that I'll keep in mind. If I see something abnormal, then I'll go to the B lines on the, but I generally, unless I have a suspicion, don't go look into the abdominal aorta. Maybe I should. And the other view with the suprasternal notch, something definitely I wanted to get into. I know Will Mack from Cohen's in New York does do that, but personally here, I generally don't do that.
Yeah, it's definitely not something I would normally do, but it's kind of one of those things that might be worth a practice if the patient is willing, let's put it that way, just to get an idea of how fast you could do it, and how feasible it is, just to gain that experience if all the participants involved are willing.
Were you using the normal cardiac probe, or did you have a smaller version?
We have, so we use a T7, and we call the P11. It's just 11. It was a phased array, but it's 11 megahertz. So it's almost like a vascular probe in a way. Like it's handy because it's small enough that you can get into tiny places like chubby necks and things like that. But I would think you could just use a vascular probe as well. But we were using the P11, the 11 megahertz phased array. It's so close to the surface that, I mean, I probably could use a little hockey stick probe that I have, and that would work okay too. That's right, there goes another plane. Okay. This is actually a shout out to Rosemary, which I don't personally know, but she influenced us in one of the previous POCUS meetings. She had talked about how she would reduce a torsion, and she was very dramatic with her hand gestures, so it made everyone laugh. But it inspired one of our fellows to really get in there and see if he could reduce. So this patient came in as a 16-year-old who had testicular pain for 6 hours. Got the ultrasound done in triage, and before we even got the results, we were looking at the ultrasound, and he was like, "Dr. Emborsky, I don't see any flow on this ultrasound." So he went in with the ultrasound machine and found this and didn't see any flow. So he did the reduction. I shouldn't say, he detorsed, sorry, about 90 degrees, looked again, didn't see great flow. So rotated another 90 degrees, and then he found that there was much better flow. So we practiced looking at flow. And this is again, that arterial waveform, that spike, which is kind of what you'd want to see again, like kind of the what we were just talking about in the subxiphoid view of your aorta for coarct. This is what you prefer to see with an arterial waveform, especially, and also with testicular ultrasound after you've detorsed. But it's important to put that gate right over the vessel, and then you kind of just need to watch for a few minutes. You can actually hear the whooshing sound. But this is the image that you would like to see. And then this is just a venous waveform as well. So it's a little low flow state. But we were very happy with this. And the urologist kind of showed up as we were finishing this, because we called him regardless, just in case. And he was like, oh, all right, we're good. I'll take them later, so it wasn't a rush to the OR on a Saturday morning. But we did realize when we looked back at our images, when we were trying to look at the resistive index, was just a good practice, right? To look at it's the peak systolic velocity minus the end diastolic velocity over the peak systolic velocity. So we have velocity over time, and where our calipers were rushed, but the calipers were here and here. And afterwards we're like, well, that was wrong. The calipers need to be at the peak systolic point, and then the end diastolic point. So if you then do the calculation, it still ended up being about 0.7, which is okay, especially since he was feeling better and we could see good flow. I felt pretty good about that. But it was just an exercise in how do you do the resistive index, which again, it's just keeps everybody interested in what's the next step, what's the next thing that I'm doing as I'm doing these Dopplers on and like the testicular ultrasound is just one of the fun things that you can do too. And he felt a ton better, very happy. It worked out really nicely. So that's a shout out to Rosemary for inspiring through one of these P2 focus meetings.
Yeah, Rosemary, we were proud. Did you have to get a confirmatory ultrasound?
Yeah, it's actually after the reduction. No, our urology doc said he's happy, and we actually stayed in the room with him and looked at it again, and he was very happy to see the flow, and so he didn't feel like we needed to get a confirmatory ultrasound. And he ended up going to the OR a few hours, not right away, it was a few hours later, and he said everything looked good and fine. So it was something I was thinking about too, like, do we trust ourselves enough with this? But I think staying in the room with him and showing him that he felt very comfortable with not having to do a confirmatory ultrasound. But yeah, it was on my mind too. Okay, so this is my last case, I think, yeah. Sorry, I'm probably talking way too fast, but this just happened on Monday, and one of these cases that just you have to kind of flip around when you're given you don't want to anchor, I guess, on someone else's opinion. But so this was an 8-month-old who was transferred for meningitis, but had a really stiff neck, he said, and was looking really ill enough to just go ahead and give ceftriaxone because they couldn't tap there. Actually flown up here by Mercy flight because he didn't want to wait for our transport team to go down and back. So came in, and it looked kind of crappy, honestly, but Pal had a small and flat fontanelle, had a lot of cervical lymphadenopathy. So in my mind, I'm also thinking retropharyngeal abscess, very dry mouth, and had a lot of pain when you try to move the neck. So I could understand that. Had really good aeration, no murmur, abdomen was slightly distended. It was kind of grunty in there, cap refills 2 to 3 seconds. So got the sepsis workup. White count ended up being 3, a little anemic, had 34% bands though. And so lactate was only 1.1, which I was kind of surprised about. So we ended up, I had a fellow with me who was just scanning, and so he had already gone in there and was basically scanning every part of this kid's body, but was doing the IVC as I walked in, and to me it looked a little collapsed, which didn't surprise me that much, but it certainly wasn't plethoric. The cardiac exam otherwise was fine, and then we scooted down to the lung, and we found this. We have a left-sided pleural effusion there with some consolidation. So I hope everyone can see that there's some fluid and we have a lung that's kind of waving a little bit at us there. Hopefully you can see it on both views, but this, the image on your right was probably up almost in the L2 region, so quite high, but still over in the axillary, I guess, because we don't see the kind of heart underlying that, but pretty good sized effusion, and that's the chest x-ray below. You know, it's impressive when you do the ultrasound compared to the x-ray, because they did read this as a left lower lobe infiltrate with effusion, but when you do the ultrasound, it's so much more remarkable how much of effusion there really is. So I tell my fellows frequently, like, just ultrasound the heart, or like the lung, just look at the lung, look at the lungs all the time, because they can be, it's just so much more impressive and help guide your management a bit better. This patient ended up having a negative tap. We did the tap anyway, because of how stiff the neck was, and she ended up having a parainfluenza. So another one of these cases where inflammation in the neck, you know, inflammation in the lungs, we have a pleural effusion, and have a white count of 3 with bands, and then ends up being parainfluenza positive, but was sick enough to go on high flow and got antibiotics and things like that, and I think it's doing fine. But they also had a MISI workup too, that I think most things came back fine, and they didn't chase that much more. I think actually got an official echo too, which was normal, but it just impresses upon how much, I guess the bottom line to my presentations were that you might find some surprises by doing ultrasounds, and it's worth giving it a go, and just trying to improve your skills so that you can only supplement your exam and your labs and your normal radiologic findings. So I think that might be it. Those are my cases. I hope they were okay.
No, they were very interesting. Great. So thank you for presenting. Do you mind sending that link about for the cardiac evaluation?
Oh, yeah.
Because I know, like, yeah, when you're viewing it as a recording, you're not able to click on it. So that would be, I think, would be helpful.
Okay, let me see. Should I just put it in, like, I can, do you want me to send this to you, like, specifically?
Yeah, we can do that. Yeah. Yeah.
Okay, I'll do that. And that way you can just, I don't know, add it in or something, but, or I can put it in the chat, but yeah. Does anybody have any questions? Have you had opportunities to do some of these cardiac, anybody else, the babies and looking for congenital heart disease? I'm just so curious. Besides Henry. Not really. All right. Stop that. Cool. Well, sorry, I know I ended a little bit early, but
No, that's fine.
What's it?
No, so it's totally fine.
Okay, good. I'm also wondering if I could take this crew for a few minutes just to ask about your if and how you are doing education with the pediatric residents. If you have like a set curriculum for them already, or if you're still kind of in the works with that, or if there's anything. I just wondered how people are doing that. We have some critical care residents who are interested in critical care, and we feel like it's important for them to learn the basics of ultrasound, and just wondering, like, over time, do you guys have a set curriculum for that?
Hey, Mary, I'm Matthew. I'm at Cohen's. We actually have just started developing that at our institution. So for the past several years, we have had an intro to ultrasound for the incoming interns at the beginning of the year. The first year was the year before COVID. We even knew what it was. And we did an in-person hands-on workshop where we covered bladder volume, lung, cardiac, And then some other things like neonatal applications, more of like a, hey, this is where the field's going type of didactics as opposed to hands-on. Last year, it got really positive reviews. So last year they were asked us to do it again, and then because of COVID, we weren't allowed to do in-person scanning with them. So we converted it to an online didactic with small groups where we very step-by-step went through, okay, look at this scan, put an arrow. How would you describe this area of the ultrasound? Okay, why is the area behind it brighter? That's what we call posterior, like very deliberate in the questioning, but very much interactive, so that even though they weren't scanning themselves, we really walked them through, okay, if the Z is here and this is where it is on this picture, what is the orientation? What type of image are you getting? So we walk them through very deliberately, bladder volume, lung, and lung. And then we also very briefly covered vascular access because that was something the residents had requested. That also got really good feedback. So we did that again this year, and again, it went pretty well. In addition to that, they are able to do scan shifts as a senior when they do a sub-I in the emergency department. They're also able to do scan shifts. They have a curriculum where they're able to do an extra half day of clinic in a field that they're interested in. So if they're interested in private practice, they get matched with a community pediatrician. If they're interested in academic pediatrics, they do an extra half day at the clinic here. If they're interested in a subspecialty, they might join that subspecialty for their clinic for a half a day a week. And if they're interested in EM, they can rotate, do an extra half day of a shift per week in the ER. And in that time, they can schedule one of their shifts every few months doing scan shifts with us. And then they can also do a rotation in ultrasound as a senior that is not limited to people with an interest in ultrasound or in emergency medicine. That's also open to people who want to do critical care or NICU, as well as hospitalist. We allow any of those people or people with those interests to do that rotation. And then finally, if they're doing a sub-I, I think I might have mentioned that already. That's another one. If they're doing a sub-I with us, they could do some of their shifts with us doing scan shifts. The director of the residency actually has approached our director, Dr. Tang, to think about creating a curriculum where they all get credentialed over the or certified or whatever. I always get confused with those terms, but get signed off basically on basic applications over the course of their 3 years, but we just don't have the manpower quite yet to be able to fulfill that request. But it's on the horizon. We're just trying to figure out the logistics in the next few years.
It's awesome. That they must be really thankful for that, because I feel like peds are a little bit at a disadvantage right now. I feel like we're a little bit behind, and it's nice to see that you guys are advancing things a bit. But I have an EM resident, we have a peds resident. EM knows how to ultrasound a lot of stuff, and peds is gone, how do I do this? So that we've tried that too, where we have like an elective and they do procedures and they learn ultrasound and they have to watch videos and things like that. And we have the intro to ultrasound course for EM, but it's trying to get those peds guys in there too. And that's it's a lot of residents.
Mm-hmm.
So we were thinking if we just started with the first years, then they could, and then, from then on, every first year would go through the class, but it's a lot more to add to your curriculum.
Yeah. One of our fellows who's interested in ultrasound is actually, her fellow project is, it's not all encompassing, but a very specific curriculum she's calling gel rounds for the residents that is very, very specifically targeting lung ultrasound. So she is, over the course of the next 3 years, going to be having a set twice a rotation on one of the inpatient floors. They're going to select patients to scan on the floor doing lung ultrasound, and then have a didactic, sort of like a tape review didactic for the entire group that's rotating on that floor. And over the course of the month, at least half of them will hands-on scan. All of them will have gotten the opportunity to participate in tape review. And she, in the tape review, is also going to sort of plant pathology so that they could identify pathology that might not be on the floor. So hopefully over the next few years, they'll at least get lung. Reason we chose that is we figured out of the ER, that's probably the most useful application, diagnostic application, to sort of track progress, worsening, development of an effusion, things like that. IVs, I think, are going to be high hitters as well, but that's more of a procedural. And she wanted to focus on a diagnostic modality. And then there's a little bit of clinging to turf to be nice about cardiac, which also would be a good one for the floor, but cardiology is having trouble with us as faculty doing it. So I don't think they would be very happy with us disseminating it to trainees. So that's where we are.
Are you using just butterflies on the floor, or do you have a?
They do have a machine on the floor. They have a hospitalist that's sort of the point person. She has done a lot. She's not trained in ultrasound, so she's still a little apprehensive in disseminating it on her own. I think this will be a nice step, because I think as the residents get more comfortable with it, it'll push the faculty upstairs to be a little bit more ready to do stuff that they just need a push. I think a good number of them are actually quite good. They just are like, oh, I could just get the X-ray. You know, I think that's where they are, because they are good. We review their scans, and when they submit them, they're perfect. They get in full studies. They interpret them correctly. So
that's great.
They just need the little push.
Well, thank you for that information. That's very helpful. I appreciate it.
You're welcome. Yeah, let us know if you need any help or any resources that we might be able to share.
Thanks. And tell Anita I said hi. Anita Pillai.
Well, she's actually working right now. Oh, no.
Tell her that. Mary Emborsky said hello.
I will. I'll pass it on.
Thanks. Appreciate it. Well, I appreciate it. If anybody else has any thoughts, you can always email me separately, but I know everyone has to probably get going. And again, thanks so much for listening and for doing this. All of you who are on the line, I think it's wonderful. And so keep doing it.
Thank you, Mary, for presenting. Yeah.
Different, Matt. I'm down in South Carolina.
Yeah.
So I do peds resident wise, I do a weekly lecture to them. Like every Wednesday I do a lecture. And that was sort of laid out in discussion based on their academic schedule. And they have our peds residents every Wednesday afternoon have their all of their academic stuff is sort of crammed into the afternoon.
Okay.
And so we basically, when I discussed with the chiefs, thought from a time use, we sort of target it to the peds residents who are specifically on the ED rotation at a time. And sort of they're expected to come in. They're protected from shifts in that window. So they come in like the hour before the rest of their half day. And I just do a cycling 4-week curriculum that covers kind of like an intro soft tissue and then fast cardiac and renal, sort of hitting things that I think are sort of high yield from an EM perspective. Ends up usually being like 1 to 4 residents at a time. So a small group in an hour, and we get to do like a 20-minute didactic and then hands-on scanning, which usually ends up being me.
Yeah.
But it's been received well. I mean, it's a lot of work because literally it's been like every Wednesday the entire year. We have our adult emergency ultrasound conference Wednesday morning. So it's sort of a natural transition. I sort of do that, do my lecture, kill time in the afternoon. I'm on like our double shift from like 5 to 2 a.m. So I just have like an 18-hour day every Wednesday that
just an 18-hour day.
Like clusters it, but lets me get a lot of stuff done in a day. I had tried the year before that to do like a longitudinal, like 1 a month lecture. But probably everywhere, everyone's academic, like there's so many demands for such little time of like protected teaching time that it ended up being like an optional noon conference, which at the beginning of the year, like half the class would show up to. And then by respiratory season, it just like slowly died to like basically nothing. And then COVID hit and shut everything down. And then I similarly offer any of them that are interested to do like an elective, which is basically just like tagging along with me doing scanning shifts. And then I usually try to do a didactic or 2 before each shift so we can have something to focus on for, they can do cardiac and scan as many hearts as they can in a shift and then scan anything of like clinical relevance while on. We've only had like 3 or so of them do that so far, but including one of our current fellows who did it as a resident, and he certainly came in you know, ahead of the game from an ultrasound perspective.
Yeah. Okay. That's nice. I get very little protected time, so I have to think about how to do this. And I probably will utilize my Penn fellows and EM residents who are in the track for ultrasound. And but it's super helpful. So thanks for sharing what you do.
On the topic of education, we actually in 5 minutes have a guest lecture coming to our ultrasound administration block of lectures for our ultrasound fellow. He's going to be talking about the use of deliberate practice and mastery learning theory in ultrasound education. If you guys want to join, we've just put the link in the.
Oh, it's so nice. Thanks. I have to go teach PALs.
Oh, that's a good example of deliberate practice.
We're recertifying all the second years, so I gotta go.
All right, guys. Thank you.
Bye.
Thanks, everybody.
Thank you, Mary, again for presenting. Thank you.
Okay, sure thing.
All right.
Bye.
Have a good day, everyone.